Hey, my name is Mark Schwetz, and I'm a developer at Chariot Solutions, and I'm so excited. I've been waiting for a year for this talk, literally. Every so often, the work we do actually makes an impact on people's lives, which is why I'm so excited that Christoph Baglieri, the Senior Vice President of Engineering at Blackfynn, is here, and where he uses big data to find a cure for Parkinson's disease.
So, one, I just wanted to say welcome. But before I dive in, I did want to take a moment just to say two things. One, I wanted to applaud the ETE team because I know I can only imagine the amount of effort it has taken to transition this event to being purely digital and putting it on. And I'm sure that was no small feat. But especially right now, I really appreciate that because it's just it's good. It's a really good thing. And so, one, thank you to that. Two, I actually also wanted to thank everyone else just for attending. I was just talking about this. Like, I'm very much a social creature, and so hunkering down like we've been hunkering down over the last month, and like not seeing my friends or my neighbors, my colleagues, like that has definitely been very challenging for me. And so I'm really grateful. And I was just talking to Tracy about this. I'm really grateful that I get to spend a little bit of time in my day today with all of you, not trying to keep my house from falling down with my kids and everyone running around and not working. So this is a real treat for me. So thank you everyone for attending. Okay, so comically, I did want to start here. So this tweet passed my radar earlier in the week, and I had to laugh. Is because I was supposed to give a talk like this a year ago, the last ETE. And the night before, I was completely dismantled by food poisoning and knocked me out for a couple of days. It was really bad, by far the worst I've ever experienced, and super bummed, super disappointed. And so when I saw this, I started thinking about like, I remember when I was re-invited back to present this year, and I remember one of the early thoughts I had was that it was something like, there isn't a shot in hell I'm going to miss hopping on this stage and presenting this. And then I was like, so here I am. There's no stage in my house. And so I feel like this is partly my fault. So I do apologize for this, but I had a good laugh of it. And so for those who do see this tweet, a lot of the comments on are pretty uplifting and funny. So it's definitely worth a look. Okay, so let me dive in a little bit. So let me spend a minute or two on myself because I think it does frame some of the work that I do. So I'm head of product over at a company called Blackfynn. We're over in Center City. Right now we're fully distributed. We'll see how that changes over the coming months. So Blackfynn is, we're a data engineering company. And more or less what we focus on is improving the clinical outcomes and frankly just accelerating the therapeutics to market broadly for neurological disease. So we focus on the brain. And what I'm going to talk about today is how we and folks like ourselves, technologists, help to do that. And so part of my talk is going to be non-technical. I'm just going to talk about the landscape that I operate in and some of the problemscapes that I deal with. And some of it's going to be a little bit technical, just talking about how the software that we build and the data science methodologies that we apply, how those play a role here. So I'm super informal. I don't have Slack open to capture questions, but as questions come in, I'll definitely answer them at the end. And like I said, I'm very much an open book. So my background, I studied computer science and bioinformatics. So for those who are not familiar, bioinformatics is you took molecular biology, statistics, and comp sci and slammed them all together. What falls out is more or less bioinformatics. I am not a bioinformatician by any stretch of the imagination. But I know enough science to be dangerous, which is good enough for me. The majority of my career, so I've been building things for 20 plus years. So the majority of my career, I've had some offshoots in the consumer space, but most of it has really been in research and development. Some of that's been in the clinical space, just helping like clinical research. Some of it's been in the in industry at biotech and pharma. But I've also spent a lot of my career just in healthcare and trying to improve those systems. And while these worlds aren't necessarily not the most glamorous at times, for me personally, I do find them to be the most rewarding. And so if I could keep, just as a quick plug to these industries, I mean, I think, especially now, you can imagine, in the state of the world, the ability to handle disease at large scale, the ability to do telemedicine, the ability to do healthcare better, we could have a large impact in that. And so that's just really my plug to say that healthcare and R&D is a really great way to flex our technical muscles and help sort of raise the bar for lots of people and have good human impact. And so that's kind of where I've tried to invest my energy in my career. So, I wanted to start here, and I wanted to frame how folks like us who are really good at pushing around ones and zeros, how can we make a dent in a really big problem, right? And so I want to take, everyone take a moment and just consider your world and consider and think about how you might be impacted directly or indirectly by a neurological disease, a neurodegenerative disorder. I would imagine a lot of us are. Like for me, my grandparents both battled with dementia, and that was incredibly difficult, especially at in their last years of life. Very tough. My wife's family, it's riddled with Alzheimer's, and so that's obviously a concern and something that I know she's worried about. Like I did 23andMe. She was always hesitant to do that because she's like, well, do I want to learn about my risk factor there? How's that going to impact my day to day? We're all living longer, and so a lot of us, we're going to encounter this in our lives. And I think the craziest part about all this is that, and I don't think this is fully grasped broadly, is that we don't have any drugs to treat neurodegenerative diseases. We have drugs to help deal with the symptoms, but we don't have one therapeutic today that more or less cures these diseases, and that's scary. And so there's a lot of reasons for that, but one of the reasons is we don't understand the mechanism of these diseases. And the rest of this talk is going to talk about how do we start to understand those mechanisms so that we can move the needle on advancing our research and understanding how they progress and understanding how they can be treated more effectively. And so that's what I'm going to talk about today. And I'm going to start with Parkinson's disease, since this is where I spend a lot of my time now. So at Blackfynn, we have a large partnership with the Micheal J Foundation, obviously, and they're one of the premier organizations focused on finding a cure for Parkinson's. So broadly speaking, Parkinson's affects about more or less 1 million people in the US, 5 million in the world. It's not a small disease in any shape or form. It's more or less caused by a death of dopamine cells in the brain. And so, when you have a dopamine deficiency in your body, you see a bunch of symptoms. And so the most common ones that people are familiar with are tremors, right? You see people shaking. There's all different kinds of tremors, but those aren't the only symptoms. There's muscle stiffness. There's a bunch of other ones as well, but they could be fairly crippling and really impede your ability to live life. What's pretty amazing though is the way we treat Parkinson's today, or the symptoms, is the most prominent drug is a drug called levodopa, which is effectively dopamine. But what I find fascinating about that is, if you think about it, the number one, the best Parkinson's treatment today is a drug that was more or less invented and created over 50 years ago. So 50 years, we haven't done anything better than that. And I don't like that fact. I think that's terrible. And I think that speaks to the challenge that we have here. If the best we have is something that we had 50 years ago, either we were really good 50 years ago and lucky, or we're just not even, we don't have the tools yet to really advance the science here. And so, I think that illustrates what I was trying to say earlier, is that we don't understand enough about these diseases and this disease type to really start making meaningful impact. And so I'm hoping I'm going to be the only one ever at a technology conference to talk a little bit about molecular biology and drug discovery. So I'm going to promise only 2 slides. I'm going to nerd on this a little bit. Like I said, I know enough science to be dangerous, but I think it does help frame the problem that technologists are entering here, the problem scape. Okay, so I'm not going to necessarily talk about the central dogma of biology, but I did want to share that I'm gonna paint a picture on about oncology and cancer, because I think its history over the last 20 years is a really good backstory that you can juxtapose neurology against. So, if you go back 20 plus years ago, I was working up in Cambridge and Boston at the time, and it's really when I became enamored with the life sciences. The Human Genome Project was in full swing in a very aggressive way, and with that effort, our understanding of genomics-based diseases and frankly our ability to treat them really started to explode. And cancer is a phenomenal example of that, right? So cancer is predominantly a genetics disorder, okay? And today, if you catch cancer early, depending on the cancer, of course, you have options. And a lot of those options can be pretty optimistic. Part of why we have those options today is because our ability to sequence genomes and to get a large and massive set of genetic data to explore and to navigate, to interrogate and understand. We learned a whole hell of a lot about the mechanisms of cancer. And so when you have that understanding, how you treat diseases changes radically. So this is the last nerdy science side, I promise. So, let's take a specific type of cancer. So let's take non-small cell lung cancer, okay? So when let's say I have lung cancer, I don't go to the doctor and I don't say, here's your lung cancer drug. Like that's not how it works. Instead, we want to understand that particular lung cancer, because underneath that, there is a biological mechanism that has just gone awry, okay? It's off the charts, it's not shutting off, or it's not turning on. Something is happening that is causing this cancer to grow inside my body. And so in the case of non-small cell lung cancer, there's a particular mechanism, it's a checkpoint inhibition mechanism. And the key player in that mechanism is this PD-1 molecular target. So that molecule plays a really big role in the checkpoint inhibition mechanism. It just so happens that mechanism underpins a whole bunch of cancers, right? Not just non-small lung cancer, but bladder cancer, lymphoma, cervical cancer, and others. And so that changes the math. It changes the math economically, because now as a company, I invest all this research and energy to come up with this drug and to treat and to test it with patients in clinical trials. But now that drug has many indications. I could use it in many different ways. So economically speaking, to shoulder those costs, the models are a lot easier to work with. Two, for every bit of work that you do on the research side, the impact factor on the other end is exponential, and that makes the problem much more tractable, right? It's if we had to devise a drug for every single cancer, we'd fail. And so we need this understanding of disease, understanding of the mechanisms to make a meaningful dent. And so today, I'd say neurology is more or less where onco was 20 years ago. And so we have a lot of work to do. And neurology is much more complicated than oncology. The brain is a very complicated organ, one. Two, and we'll talk about this further, it's not just a genetics-based disease. And I'm minimizing cancer, but the vastness of the data that we need to deal with and wrestle and understand is much, much greater. And it's also just, the landscape is just very different. And I'll talk about that, why. Okay. So let's exit out of molecular biology. And so congratulations, everyone. You all now have survived Science at a Technology Conference. So let's go here. So to begin to understand the mechanisms of disease, and this is talking a lot about what I focus on day to day, is we need data, and we need a lot of it. And luckily, a lot of data exists. But the only challenge is, particularly in neurology, it's really disparate, and the landscape is incredibly challenging. So consider this, and I'll use again cancer as an example. So I get cancer, I get really sick, and I get really sick within a fairly small window of time. We're talking years. Go to the doctor, they do a bit of research on me, and they try out some cocktails to see what's going to work to help me with my cancer. We find a medication that works. In that small window of time, I'm constantly going to the doctor, constantly doing checks. I'm constantly reporting how I'm doing. All of that data is more or less collected in one place, right? The electronic medical record. So there, the breadth of data types is fewer, and two, it's in one spot. Not trivializing that in and of itself is very challenging, but some of the variables are solved for us. Now consider Parkinson's disease. I might have Parkinson's disease for 10, 20, 30, 40 plus years. I might go to the doctor a couple times a year at best. When you look at some of the observational trials that are out there for Parkinson's, I'm going twice a year. So the distance between one set of data to the next is great. Two, there's also this phenomenon where, especially with a lot of neurological disorders, where patients perform for in a visit, right? So if I'm sick and I know I'm going to the doctor tomorrow, I might go to bed really early. I might wake up early, put on get dressed up, have a good breakfast, and I go into that doctor's office and I'm going to perform. I'm going to say, I'm doing great, doc, feel good. I'm feeling really good, because you want to be positive, you want to be optimistic. That is part of just life. If you have any neurologist friends and you ask them, a lot of times they'll also talk to that person's partner, because if you were to ask that individual's partner and say, well, how are they doing? They might say oh, he's doing terrible. He sleeps terribly. He says he has 3 seizures a day. Actually, he's having a dozen. And so the data that you're capturing is not always correct. Two, the sources are really varied. You have these diseases for a really long time, and this is happening at the regulatory space, right? Patients are becoming involved in collecting data. So patient-reported outcomes, where I, as a patient, am sending in observational data about me to my doctor. So that makes the landscape in neurology very, very difficult. And so what we need to do as technologists is we need to do what's on the left side of the screen here. We need to invert how researchers are spending their time. And so one of the things, one of the co-founders of Blackfynn early on said to me, which really stuck with me, was that this guy's brilliant, PhD in neuroscience. And he said, you know what, when I was going through my PhD program, 80% of the time I spent had nothing to do with studying the brain. 80% of the time just had me wrangling data and just all the things that I don't want a PhD neuroscientist doing. I want them looking at the data and telling me how my brain works and helping me figure out what the hell is going on in there. And so the technology that we use, the data science we use, is really intending to try to flip that ratio. I want researchers to use very little time organizing their data, and I want them using most of their time figuring out what the hell is going on with these diseases. And so that, to me, is where technologists such as ourselves can really make a meaningful impact in this world across all Parkinson's, for example. And so how do we start to do that? Well, one, this is inherently a multidisciplinary problem. And a lot of people tout that they're multidisciplinary. There is no way that one person can have all of the knowledge to make a meaningful dent in this space in one head. It's impossible. And so you need to bring the right people to the table. So you need to bring neurologists and neuroscientists and clinicians who understand the questions that need to be asked, understand the right data sets to collect, understand how to harmonize and integrate all of that. They have knowledge of that domain. They speak a very different dialect though. And that's one of the reasons why I wanted to study bioinformatics, because I really wanted to be able to bridge dialects. And so that was my impetus for studying that. But then you also need a ton of technologists. You need data scientists and curators to amass and stitch together that broad ecosystem of data. You need lots of data engineers, lots of different software engineers, and frankly, a lot of security engineers. This data there's a lot of patient data in there. And so with that, there's other impedances that we have to navigate. So there's a lot of really intelligent engineering that has to happen here, and tough scaling problems. And so what tools do we use? We use the same tools that you use in any other industry. We use a whole lot of AWS. Everything we do is all on Amazon. And so I know more about how to build a secure system on Amazon than I ever thought I would ever have. We use, most of our middleware is Scala, some Python as well, but most of it's Scala. This has been my first foray into probably the largest functional effort that I've ever been involved in. And so Scala's been great for us there. Not without its quirks, but it's been really great for us. You need all of our web clients are all JavaScript. We use a ton of JavaScript. We use a little bit of Rust too. So we have command line libraries that interface with all the systems that we build, and we need them to run on all environments, Windows, Nix, OS X, etc. So we use Rust for that, and that was really valuable for us. We use all the frameworks that we use everywhere else, Akka, Vue, Scalatra. On the data science side, it's a metric ton of Python, a whole lot of Python, and a whole lot of use of the libraries that I'm sure we've heard about over the last day and today as well. And Pandas, Scikit, Jupyter, etc., Scilern. And all this is containerized. So the same kinds of things that we're doing in the consumer space, in the commerce space, in the financial space, we have to do here too. And so, the recipes that we could look and the open source tools that we could leverage and use elsewhere, there's no reason why we can't use them here as well. And so we're bringing the right people together, we start using the right tools, we wrangle that data. So what are the things we could start to now glean from it in a more meaningful way? So what kind of insight can we elucidate from this data? Well, let me give 3 examples. So one thing we could do is we could start to stratify or cluster patients and understand the biomarkers that make them unique. And so, you can consider 2 people who have Parkinson's. Like I might have Parkinson's, and let's say my wife does. I progress much more aggressively than she does. Why is that? What is there some clue, some like phenotypic or some observed clue about me that tell sign for like why I'm progressing faster? Maybe there's some biological clue. Maybe there's some mutation in my DNA that says like, oh, Chris, you're in a group of a patient population that you're going to progress faster. That's really valuable to know that information. So that's one area we can start to glean from a holistic and integrated data set. This is a big one, optimizing trial design. So, a lot of times drug trials fail, not because the drug sucks. It's because we don't have the right participants in that trial. So anytime you get bad data or an adverse event, odds are, just because the market is what it is, like the companies have to make tough decisions, and like drugs are not going to proceed. The drug might be really effective for a really well-defined group of individuals. So a real significant effort in clinical trials is like finding the right people to give that drug to. And so, imagine there's like adaptive trials where you could change them on the fly. Imagine having these models that are trained from this large set of data where you can, in real time, maybe there's some outlier data that's collected. It's like, you know what? Chris is going to fall into this category that's not going to respond well to this drug. Let's remove him from the trial because it's just not worth it. That's not the data we want. So we need a lot of trained models to be able to do this kind of stuff. Another really interesting area that's been new to me that I've had to learn about. We're not there yet, but when you run a trial, there's a control group and then a group that actually gets the drug. And so the control group or the placebo group, effectively they get a fake drug, which sucks when you really think about it, right? Like if I have an illness and I enroll in a trial, like I'm bringing an immense amount of hope with me into that trial, and I don't know if I'm actually going to get the drug or not. And so, the concept of having a virtual control arm where, imagine creating our control group digitally. I could more or less bring out one of those interesting patient populations, and the data that I have about them is like, okay, this is going to be our control group. Now I could use that control group, that virtual control group, and actually just recruit patients and give them the actual drug. And so that's much more cost effective. I don't have to have a group of people taking a fake drug. And there's a lot of human benefits for that as well. So optimizing trial design is a really, really big area that I think companies that are trying to weed through all this data can make a meaningful impact. And lastly, another area where I think data science can really push the boundaries is understanding how these disease progresses. Broadly speaking, the field doesn't necessarily know how Parkinson's progresses. When you have a disease that is running 10 to 40 plus years, I mean, the amount of factors that are involved in that time span is overwhelming. And so, being able to understand, like, Chris is not going to progress for another 20 years. So let's not give him any treatments, because that's going to put him at risk. Let's focus our energies on this group who are going to progress much faster. And so the treatment profile that you take on when you understand how a disease progresses is radically different. So that's another area where, and I'll show a good example of this, where software and engineering and data science can really make an impact. Okay, so that's more or less, let me check my time here. Good. So that's more or less chapter 1. So what I wanted to do here is I really wanted to frame the problem, frame the challenges, and more or less kind of encapsulate what we're dealing with here. So just to recap before I switch over to now more data focused stuff. Broadly speaking, for most neurodegenerative disorders, we lack an understanding of the biological mechanisms that are underpinning them. As a result of that, we kind of have our hands tied behind our back to make meaningful progress on therapeutics and just research in general. 2, we need data to change that. And while we have data, 3, the landscape to navigate it, to pull it all together, is immensely challenging. And so that's the problem that's on my horizon. That's the problem where we are today, where technology can make a real impact. And so now I'm going to shift to chapter 2 being much more data science focused. And so what I'm going to do here is I'm going to walk through very high level there are any data science effort, there are more or less phases of it. And so and every phase is every workflow is a little bit different, I would expect, based on the problem you're trying to solve. But for us, the 4 phases that I'll walk through is: 1, there's organizing your data, and I'll show what that necessarily entails in my world. 2, there's modeling and harmonizing that data that you've organized. 3, there's broadly exploring it at a very high level, just to kind of get a feel for what's there and the shape of it. And then lastly, 4, there's diving in deep and really analyzing it. And so that workflow is the workflow that we follow with the data that I've been talking about thus far. So let's spend some time on organizing your data. So I alluded to this earlier. So the breadth of data types that we encounter in neurology is pretty vast. So if you think about like doing this for commerce or finance data, there's a ton of it. You're dealing with a metric ton of data, but the shape of it is more or less the same, right? In the scientific domains, the shape of data is jagged. It's all different. There's also a ton of it too. And so the dimensions of big data, there are many. There's volume, but there's also the shape of it is really complicated. And third, it's just incredibly noisy. And so, in neurology, you have many different types of data. So you have certainly many types of imaging data. So you have 2-dimensional imaging data, right? So those pink and purple slides that, if you've ever had a tissue sample taken, we have that. We have a lot of like MRI data and imaging data, 3-dimensional imaging data of your head, or many images that are stacked on top of each other. We have lots of time series data. So like the meshes you put on patient's head and the diodes and everything to basically measure brain activity. This is really big in epilepsy. So there's time series. There's also time series data that's coming from devices and sensors. As I was saying earlier, because these diseases are running over so many years, patients need to be really involved in helping provide that data. So, streaming my data from my watch, or reporting or sending my data to some system that can aggregate all of it, or keeping like sleep logs, that kind of thing. So time series data from devices is certainly another source of data. Video is actually a really big thing. in Parkinson's. You got to remember, most of these disorders are movement disorders. And so they have a lot of tests where they might measure how I walk and measure how I move and turn and my gait. So all of that, that's all real useful data. And there's also just a ton of tabular data as well. There's still omics. There's still a genetic factor in all of this. And so at the end of the day, genomics data is really just massive, massive, massive sets of tabular data. And so the landscape of data types is crazy vast. The sources of data are also really vast. And so, going back to cancer, there I have my EMR is basically my source of data. Neurology is all over the place. I already talked about devices. There is retrospective data, meaning observational data that's been collected and is made available to download and to use. You would think that those data sets the lift is not very high. Data sets that have been around for 10 plus years. You would think at this point I should just download and be able to run with it. One of the main data sets, premier data sets at the Micheal J. Fox Foundation, it took us, folks who are talented and understand the data landscape, it took us months. I would almost say like a year to the point where we modeled, had a really interesting model on top of that data set. And so that year that we invested, think about if another researcher came along, they're not standing on our shoulders and building from there. They're starting from scratch. And so the sources of data are really, really vast. We have prospective data, meaning data that's being collected right now in trials. We want to pull all that data in. We have data that's coming from devices. This device here looks like a pacemaker. It's not. That giant thing is a battery. That lead actually gets inserted into your brain. So this is a deep brain stimulation device. Just a quick anecdote, and I talked about this on the podcast I did over a year ago when I was supposed to present this stuff. I'm pretty sure one of the most surreal things I will ever get to do in my career had to do with this device. So early on in, at least at Blackfynn, I don't want to say it was a pivot, but early on we really focused a lot on medical devices and interfacing with them. And so for a good chunk of time, we were working with a large device company where they had a few dogs that were experiencing seizures, and their medical device was implanted in a couple of those dogs. And so that's what you see here. And so those leads were inside, like physically inserted into those dogs' brains. And so we built a system that was streaming brain data from dogs halfway across the country to us in Philly in real time. We were ingesting that data, doing some real-time analysis on it. And ultimately what we wanted to do was close the loop and actually tune the device back in the dog's brain, which was insane to me. We didn't fully close the loop because we decided to go a different direction. But you could appreciate, one, the volume of data coming out of that device, and two, the amount of engineering to do that was ridiculous. And so while in some ways look back, I'm like, we're not really using that or doing anything with that right now. These are engineering problems that have to get tackled. And so, going back to like our role, like this group, this room, we're gonna have to figure out how to do that. When you hear like Elon and others like tout like Neuralink and things like that, the amount of infrastructure required to one, just capture the data, and two, do something with it is orders of magnitude more than what we have today. And so this is all part of this landscape. So the sources of data are really vast and really complicated in and of themselves. So what kind of tools do we build to help organize the data? So this is one of our things that we built at Blackfynn. The way I often describe it to technologists, this is like our business intelligence platform for research data, right? So I have a single platform that allows me to handle diverse data and all the various types that are relevant in neurology. I have tools to allow me to annotate it and describe it, and then search over it in a meaningful, guided way. I have tools that help me organize all of this data into different data sets and to share it with my colleagues, or to publish it for others to use, or to publish it into a data ecosystem, very much like all the other data pipelines we build across all other industries. And then I have rich tools and APIs to interrogate it, to navigate it, and explore it. And so this is one of the many systems that we've built out to help deal with the organization of data. Okay, so that's step one. So I have my data organized, right? I pulled in a bunch of different Parkinson's disease data sets. Now I need to model and harmonize it. And so the way I often describe the challenge here is to think of a family tree. And this was an analogy a colleague of mine used, and I loved it so much. I steal it because it's just so great. So, if you look at a family tree, just the inherent structure of it, you could glean a bunch of information, right? So if this was my family tree, you'd see I have 2 siblings. You'd see that my parents are still alive. You'd see that my great grandparents, my grandparents are deceased. And that's, there's meaning in that, there's value in that. What you don't see is you don't see that my personality is much more like my sister, and that my brother and I are very, very different. What you don't see is my mom likes to talk to me, and my dad and I just text all the time. What you don't see is that my grandfather was one of the most influential people in my life. That metadata about me is massively valuable. Frankly, that's the information that describes me more than anything else that's inherent in this data structure of a family tree. And so capturing that is really important. That's where analysis generally focuses. And so if you to translate that family tree analogy into the data that we're talking about, we have raw data. And raw data in and of itself is very valuable. We can extract features from it. We can build models from it. We can make inferences from it. That's great. But what's really important is that raw data is related to a particular patient or participant, if we want to use clinical trial speak. That participant might be on a bunch of different medications, right? That participant is enrolled in a trial, and maybe that trial issued them a Verily watch or an Apple Watch or some kind of sensor or Fitbit, right? So there's data there. That clinical trial may have collected blood data, may have run some genetic testing, may have some MRI data, and maybe there's been a bunch of observations about that have been made. So that thicket of metadata is valuable, arguably more valuable than the raw data itself. And so we need to provide tools to capture all of that. And when you look at this picture through the lens of, from a computational lens, it starts to look like a graph, right? You start to have these nodes and how things relate to each other. And so that concept space is really important. And so another area where we build tools and help to lower the barrier of entry to this data and to flip the 80% and 20% is capturing that concept space. And so what we're looking at here is a visual representation of a particular data set, a PPMI data set. So this is the data set that the Fox Foundation has anchored its entire existence on thus far. It's the premier PD data set. It's well over 10 years old. To date, as I said earlier, it has not generated any therapeutic action. That's a 10-year-old data set. Also, the modeling layer that exists on top of this, this is what took us a lot of time to really tease out. So you download these data sets now, I might get a bunch of files and I might get a bunch of CSVs. And it's like, there you go. So just imagine grabbing that, like, okay, there's no the data dictionaries are pretty poor. There's no way to say like, well, what the heck does this field mean? And how does that relate to this file? And so we've had to build all that out. And so this view is more or less an organic database that sits on top of this data set, right? It has this is an old picture, but it has a bunch of different tables, models that sit on top of it, and a bunch of different records that sit in all those models. And so from this, you could really start to query it and analyze it and explore it and understand it. And so this concept space is immensely important. So what can I do with that, right? Phase 3. Now, awesome. Now we're in charted territories that we're familiar with. Now I can fire up a Jupyter notebook. Now I could use a Python library to kind of go in there and start navigating it and querying it and exploring it in a very rapid, efficient way. Now I could operate on this data. Now I'm really focusing on the 80% I want to focus on. Right? Now I could start exploring my conceptual space. I could ask a query like, find me the patients who are diagnosed with this particular slice of PD. And you know what? I only want to see patients from the last 3 years, and I only want to see patients with this specific mutation, LRRK2 mutation. And I only want to see patients that have this UPDRS score, which is a sniff test. And I only want to see those that have a DAT scan, which is an imaging measurement that's greater than 2. Awesome. Okay, great. So now I have a really small population I'm interested in. So now I want to increase my N. Now I want to do this for much, much, much larger data set. Now I can go ahead and start doing that. Now I can find this cohort of interest. So now if I want to take this cohort of interest and I want to push that data to the tools that we've been using in every other industry for a long time now, right? I want to throw it into Jupyter and I want to interact with that data. I want to do deeper analysis on it. And I want to throw it at Spark, for example. I want to really visualize it. I want to see it in Tableau or Spotfire or all the other visualization tools available to me. And then what I learned there, I want to push back in. I want to push back into that original system and increase my intelligence of all this. And so that is where we invest a lot of our time doing exploratory work. Now, I found something of interest that I really want to dive deep. Right, so going back to the different things that we could do with this data, like patient stratification and optimizing trial design. These are just screenshots from a tool that we built that allows us to understand the PPMI observational study at a level that has never been available to date. So now I could see, like, at a holistic level, what are all the different medications that are being used by participants in the study, and how, what are all their different UPDRS scores, and how does that break down, and how does that relate to all the different subject groups there? Or maybe I want to drill down to a specific participant. How does this individual, like, what is their progression from a, like, what are the different scores that they've tracked over time? What does that look like? And now I want to, let's say, I want to understand how the disease is progressing. So we built this other tool where, now I found a cohort of interest. I want to understand, like, how this group progresses through their disease. I want to set a bunch of filters. Again, this is all powered by the metadata that I just showed. I want to filter which subjects I care about. Maybe maybe I only want to look at, like, LRRK2 patients. I want to give them some severity metric. I want to say I'm only interested in watching patients from baseline to year 4, and maybe I want to group all these individuals who are fast progressors versus slow progressors by whatever definition that means. And then through a lot of machine learning, understanding what are some of the features that predict whether one person goes fast versus slow. And so these are the kinds of things you could do once you have data that is actionable and usable. And that barrier of entry needs to get pushed down. And the only individuals who could really do that effectively are technologists and data scientists. And the only way technologists and data scientists can do that is we need to work with the folks who understand this data. And so there's a lot of dialect translations that happen in order to build something like this. But when we put this in front of PD researchers, it was really fascinating just to step back. And the whole point of the meeting that I was in was to demo this. What happened was, within the first 15 minutes, we were just starting to show the tool, and then this discussion just sort of offshoot. And it's like, oh, wait a minute, that's interesting. Why is that green line? I would have never expected to do that. Why is that? And then no one had an answer. It's like, I don't know, but this is what the data is telling us. And so it was really interesting just to watch the ability to rapidly generate hypotheses when you have data like this. And I think that's something that's been really missing is, we build software and we want to do so really iteratively and, sprint by sprint by sprint. And we want to be very data driven. We want to do the same thing in science and life sciences. Granted, they're not doing things in 2-week cycles. Science takes longer than software, but I want to take what might be, it takes me 8 months to generate a hypothesis and get an answer. If we could reduce that to, hell, 3 months, a week, the impact of that is massive. And so I want to really invest my time, engineering time, and data science time to allow hypotheses to be generated rapidly and let that iterative cycle happen over and over and over again. And that's really where I think the state of data science in at least this field can really have an impact. And so just to kind of tail things off here, we're just scratching the surface, and this is going to take time. Scope of work is really, really big. I've been talking about just Parkinson's disease, but if you think back to my earlier slide about the interconnectivity of diseases and indications, I think what we're going to see is it's not just Parkinson's disease. One, there's going to be many different kinds of Parkinson's disease. Two, I think as we learn more about these disorders, some of the mechanisms that are underpinning Parkinson's are going to be shared in Alzheimer's or ALS or dementia. And so what we're doing right now in Parkinson's, and it's taking a long time, we need to do much more broadly. And so this is going to be a long journey, but engineering and data science and just technology in general is this sort of a key pillar in all of it. So that's what I had to present. So thank you very much, and hopefully this excited folks about this field.
All right, thank you so much, Chris. We already have one question in room A. How much has your work been impacted by current events? I know that they have been limiting or pausing many clinical trials. Does this impact the data you receive? This is from Terry Tan.
That is a great question. And so the answer is most definitely yes. However, it actually also spells out an opportunity. And so, a good example is this. One of the trials that software I didn't show is we also have a bunch of software that underpins like an EDC system that fundamentally drives clinical trials. One of the trials we were supporting, they just shifted their date. The launch was supposed to be April 1st. It just shifted to currently July 1st. I suspect that may even shift further. So yes, to answer your question directly, the clinical landscape is radically being changed, and a lot of companies have had to just press pause. However, science must go on. And so like my wife is an MP, she's downstairs doing telemedicine, right? So there are lots of opportunities to creatively rethink in how we run trials. So in the regulatory world, I've been saying that involving patients is something that's much more prominent now. Telemedicine and conducting visits virtually is much more prominent and accepted clearly now. So building things on the phone that patients can fill out is a way that we can advance and overcome the hurdles that our current environment has presented us to continue to push the boundaries on what entails a clinical trial. So I definitely do not deny that that world is impacted greatly, and we're going to feel the ramifications of that for a long while. But again, I think this is where technology can really help. We have tools to help move these things forward. We just need to think about how best to use them.
Cool. Somebody asked if you would consider uploading your slides. If somebody.
Oh yeah, sure.
Yeah, we'll get them on Slack or something like that. Yeah, we'll get those slides out to people later. We've been actually discussing that as other speakers have uploaded slides. Okay, so Terry Tan asks again. You mentioned using a lot of AWS. What AWS specific services do you feel you leverage the most? SageMaker or EMR? What about storage for the large amount of data you collect?
Great question. So we don't use extensively today SageMaker or EMR. Most of our data science efforts are not on that infrastructure. We use obviously a ton of storage. To be quite honest, we use most of the boilerplate stuff in Amazon. A lot of S3, a lot of RDS, a lot of EC2, a lot of containerization, a lot of Lambda. I will say one area that we initially invested heavily in was Neptune. So we were part of the general release of Neptune, which is our graph database. We've since moved off of Neptune. It just long-term didn't really fit our needs, and the performance wasn't what we needed of it. So we've transitioned over to Neo4j. But we're a smallish team. We're coming up on 40 now. And engineering is about 2/3 of that. For the amount of software that we have, you would think we'd have a lot more people. And so we lean on, anytime we could lean on Amazon, we're going to do so. And so odds are if there's a service there, we either kick the tires and considered using it, or it could be used. We use Cognito a lot. That's been really great, honestly. And from a secure perspective, there's a lot of VPC. There's a ton of more really low-level infrastructure pieces to make sure that we're adhering to HIPAA and other compliance recommendations.
Cool. All right. So let's see. Somebody else. Does anybody else have a question?
My contact information is here. So if questions come up, feel free to reach out to me. I always love engaging. So thanks again, everyone. I really appreciate it. Like I said from the beginning, this has been a real treat for me. So now I'm going to go back to making sure the walls in my entire house don't fall apart with my kids running around like crazy. So this has been a great reprieve. So I appreciate it.